Yeah? Maybe it's coming? This one? Yeah.
Yes. I see the
Yay. Okay, super. Thank you. Okay. So, I don't know about in Europe, but in the United States, iron administration to preemies is an extremely controversial topic. So I got interested in it because of my interest in EPO several years ago, and it was one of those topics that I thought I knew about, sort of like what is there to know about iron? It's not that big a deal. And the more I started reading, the more fascinated I became, and the more I became convinced that it was actually really critically important. So I'll share some of those musings with you here today. We'll talk about why iron's important, too much versus too little. I'll give you the AAP recommendations and some information about monitoring iron status in preemies. So iron is important because there's many molecules in our body that have iron as a critical moiety of that molecule. And some of the functions include hemoglobin carrying oxygen to tissues. Myoglobin carries oxygen to muscles. There's a molecule called neuroglobin that was discovered in the early 2000s that's important in transporting oxygen to neurons. It's important in cell division and brain development, and there's actually critical windows of brain development that if you're iron deficient during that time, then even if you become iron sufficient later, that damage is irreversible. It's also important for cellular metabolism, and this is just a partial list of the things that iron is involved in our bodies. And I don't know about here, but in the United States, there used to be advertisements for Geritol, and they went something like this. Do you have iron poor blood? Are you feeling tired, poor concentration, blah, blah? Take Geritol. And this was some of the list of the symptoms that were discussed. And when I first looked at this, I thought, well, how do you put that into the context of what iron does? And so I thought, well, if you think about hemoglobin, and if you're iron deficient, a late symptom is anemia, and so you would be tired if you're anemic, and tachycardic with heart murmurs if you're very anemic. Myoglobin would affect weakness, fatigue, poor stamina, hypotonia. Actually, if you're iron deficient and your neuroglobin isn't functional, then you're at higher risk for hypoxic ischemic brain injury. And you can have immune deficiencies because of deficiencies of myeloperoxidase. So they actually make sense if you put them in categories. So again, there are critical windows of brain development, and iron is essential for normal brain development. And withholding iron from iron-deficient preterm infants can cause harm. And again, so if you become iron replete after that critical window, irreversible brain injury has been done. So iron is involved in these enzymes that I was referring to before that are involved with oxidative metabolism, neurotransmitter synthesis, so it's important for dopamine and serotonin synthesis, and also for myelination. Again, if you're iron deficient, there's an increased susceptibility to hypoxia ischemia. So unfortunately, there's a lack of randomized, controlled, prospective trials in humans because no one has ever randomized to no iron versus iron. But there are clinical trials looking at babies who have been identified as being iron deficient and then being treated. And what we know is that if you're deficient, if you're identified as being deficient by 6 months to 24 months, there's motor and cognitive delays while being iron deficient, but those delays actually don't repair if you get iron later. And the persistent cognitive delays that people have identified is decreased executive function and poor memory. Been identified at 6 months. Those have remained present up until 19 years in some of Betsy Laszloff's studies. There are populations that we know of that are at increased risk for iron deficiency, and babies that are small. You can think of this as abnormal placental transfer of iron, and also babies who are infants of diabetics. So again, there's impaired recognition memory, and the degree of abnormalities relates to the degree of iron deficiency. So I think I've pretty much said this. One thing that I think is important to know that I certainly didn't know is that the body prioritizes iron to red blood cell synthesis. And so anemia is actually a late symptom of iron deficiency. So if iron supply doesn't meet the iron demand of the expanding red blood cell mass, first iron stores are taken from the liver and then they're taken at the tissue level. So that's, you get actual deficiency in the brain. And anemia is a late symptom. So that is a reason why doing screening with hematocrits is probably inadequate, because by the time you're anemic, it's actually, you've already had tissue levels of brain anemia, and that's important for babies that with developing brain. So Michael Georgiev has done a lot of just absolutely excellent work in animal models of iron deficiency. And this is one of his models where the rats are made iron deficient between 5 days of life and 25 days of life, which corresponds roughly to a 34-weeker to about 14 months of life. And in these animals that have been made iron deficient, he's shown decreased myelination, decreased dopamine or altered dopamine metabolism, excessive glutamate concentrations in the hippocampus. I'll show you a picture of these abnormal hippocampal dendrites, and increased neuronal loss as well as abnormal behavior. And for just a second, I'm going to turn off the lights. So I hope you can see this. This is a rat pup hippocampus, and this is a normal iron sufficient hippocampus. And what I'm hoping you can see is a very regular array of dendrites that span this hippocampus. And in this animal, this is the same area of hippocampus in an iron deficient animal. And you can see this is just very disorganized and ratty. Sorry for the pun. No one laughed. Okay. So this is a prospective randomized trial that was done in human preterm infants. And babies were randomized to early versus late iron. I know when I was a resident, I was taught that babies were iron sufficient and they weren't really undergoing significant erythropoiesis for the first 2 months of life. So for the first 2 months or until they were 2 kilos, we didn't give babies iron. And that was the standard of care when I was a resident and fellow. And then this paper came along looking at PO iron 2 to 6 milligrams per kilo per day when babies got to 100 milligrams per kilo of enteral feedings versus what was at the time standard of care, starting iron at 2 months of age. And he looked at iron status at birth at 2 months when they had almost doubled their birth weight and if they required transfusion. So there were 200 babies enrolled, and there was no difference in the babies at the time of study entry. Iron was tolerated well by all, and that's always another issue is, oh, they don't tolerate it well, they're spitting up their feeds, they're constipated. There's a long list of symptoms that are associated with giving iron. But it turns out if this, in this randomized trial, the iron was actually well tolerated by all the babies. And so the results showed there were less transfusions in the babies that got iron early, and there was less iron deficiency in the early iron group, although some of the babies were still iron deficient, even though they'd gotten up to 6 milligrams per kilo of iron. He also looked at some of the common problems of iron prematurity, because there's also stories about iron being associated with ROP, chronic lung disease, IVH, infection, and so on. And basically for all of these things, there was no significant difference. This is another trial that was done looking at iron supplementation of healthy breastfed infants. And so 77 babies were enrolled in this trial. They got either 7.5 milligrams of elemental iron or placebo from 1 to 6 months of age. And several lab tests were done to assess iron sufficiency. And then these babies were tested developmentally at 12 to 18 months. And what they found was that the babies who received iron actually not only had higher hemoglobins, which you would expect, but they also had higher visual acuity and higher physical developmental index scores. So we don't want to do harm, and I think administration of supplemental iron to babies that are iron sufficient may cause harm. And so that's particularly true because iron is one of those substances that has a U-shaped curve, and the window of safety is actually narrow relative to some of the things that we deal with. So being iron deficient is problematic, but being iron overloaded is also potentially a problem. So we worry particularly about preterm infants because they're at very high risk for oxidative injury. They already have a propensity for inflammation. Many of them are born after chorioamnionitis. Sepsis is fairly common. Hypoxia ischemia is quite common. So they're an at-risk population, and they're very vulnerable to oxidative injury because they have less antioxidants. So superoxide dismutase and glutathione peroxidase are basically not really present in the first 2 weeks of life, and even when they become present, they're at lower levels early on. They also have more free iron. So in an adult, it's rare to be able to measure free iron in the blood because iron is always a chaperoned molecule. So, but in babies, you can actually measure free iron fairly commonly. And then there's cell populations in our developing preemies that are extremely vulnerable to iron. And one of those important cell types is oligodendrocytes. So excess free iron can contribute to oxygen radicals through Fenton chemistry. And these oxygen radicals are thought to contribute to several of the diseases that preemies get. We don't have any proof of that, so there's no direct data linking iron to increased periventricular leukomalacia or BPD or ROP. But on pathologic specimens and in animal trials, clearly if there's brain injury after hypoxia ischemia, there's iron deposition in those areas. So it does seem to make sense that we have to be careful with iron. If we look at states where we know there's pathologic iron overload, none of those symptoms come up, though. So what I was trying to do when I was first learning about this is say, okay, you know, these babies are at risk, and let me look at a population where we know they're iron overloaded and see, is there lung injury, is there heart injury, is there neck, is there, what are the symptoms of that? And it turns out, you know, there's several pathologic states where we know there's iron overload. So there's increased absorption with hemochromatosis. These are defects in iron transport and iatrogenic iron overload from transfusions in cases of thalassemia. So all of these states are associated with iron excess. But the symptoms that you find are liver cirrhosis, cardiomyopathy, diabetes, hypogonadism, and arthritis, none of which we really see in our preemie population. But having said that, I think iron status is a question of balance. And if you look at it, it's a matter of the stores that you're born with, the amount of oxygen that you receive exogenously, postnatally, and the iron that you use. So that just makes sense. And if you look at the stores that are present at birth, preterm babies have less iron stores than term babies do. So on average, a term baby will have 75 milligrams per kilo of elemental iron. 75% of that is stored in hemoglobin. 15% is in iron and spleen, and 10% is in tissue proteins. And that distribution is pretty standard. Preterm infants have 64 milligrams per kilo, so not only is there less total body because they're smaller, but it's less per kilo iron. And that's because 60 to 80% of iron transfer occurs in the third trimester. So if you're born at the end of your second trimester, you have not received the majority of your iron transfer. So it's not that you're iron deficient for your gestational age, but if you're born at a certain gestational age before you've gotten your iron transfer and you don't get exogenous iron, you become progressively more iron deficient. So again, there's certain groups that have a propensity for iron deficiency, and small for gestation infants have on average 40% of normal iron stores, so that's a group to be aware of and make sure you give iron early. Infants of diabetic mothers have even less iron. Babies who are exposed to prenatal alcohol are at risk for iron deficiency. And maternal smoking, that evil thing that you've been telling us about, also decreases maternal iron stores. So this is a graph of cord blood ferritin levels from normal babies. And you can see that as gestation increases, serum ferritin increases. And this is actually quite surprising to me. So the normal levels for preterm babies is much higher than for adults. And so if your serum ferritin is 40 for a term baby or 35 for a preterm baby, you're actually quite iron deficient. So what are exogenous iron sources? So breast milk has some iron in it, about 0.5 milligram per liter, but what's there is fairly well absorbed. Having said that, the AAP recommendations are now for iron administration for normal term breastfed infants. And part of the reason for that, I think, is about 30% of our mothers are iron deficient. So even though iron is preferentially put into the breast milk, there's still inadequate amounts of iron in breast milk overall. Iron absorption from formulas varies quite a bit, and for different soy formulas, 1 to 7% is absorbed. Obviously, we can give iron supplements. Ferronsol is the usual one in the States that kids get, or trivisol with iron for preemies, polyvisol with iron for term babies. And for enteral iron, babies, well, humans in general, will regulate the amount of iron that's absorbed from the gut. Unfortunately, for preemies, that doesn't happen on a regular basis until the babies are 6 to 9 months of age. So they don't regulate very well. So things that have a negative effect on iron status in the perinatal period, many of them are maternal. So maternal iron deficiency, diabetes, maternal smoking, IUGR. So this has to do with placental function. Multiple gestation, preterm birth, bleeding, because 75% of your iron stores are in your red blood cell mass. So if you lose your red blood cell mass, that's a huge piece of your iron stores. Early cord clamping, exchange transfusions, restrictive transfusion practice, uncompensated phlebotomy loss. And again, in the United States, we're terrible at this. Our average blood loss is 80 cc's per kilo, which is more than 1 blood volume. In Europe, the average is 40 cc's per kilo, which is still not great, but it's better than we do. Recombinant iron use, again, because that prioritizes iron into the red blood cells. Delayed or inadequate iron supplementation, exclusive breast milk use, or cow's milk. Things that have a beneficial effect on iron status include maternal iron supplementation. That's part of the standard prenatal vitamins. That, I think, is why a lot of adult women think that babies are going to be symptomatic by getting iron, because for adult women who take these prenatal vitamins, constipation and flatulence is definitely a side effect. Fetal transfusion if you're the recipient twin, again because of the blood. Delayed cord clamping is beneficial. Keeping the blood in the baby is beneficial. Liberal transfusion practices, early and adequate iron supplementation, or the use of iron fortified formulas. So in our unit, when I came to the University of Washington, we were giving babies formula without iron. And so I think that was, that's a fairly recent practice. There are parenteral preparations that you can use to give babies iron if they're NPO for a prolonged period of time. Iron dextran has gotten a bad name because in adults, anaphylaxis is a side effect. There's only one reported case of neonatal anaphylaxis with iron dextran, and that baby got a 6-fold over. So it's really not a problem for babies. Iron sucrose and iron gluconate are also IV preparations. And then blood transfusions. So on average, packed red blood cells contains 0.5 milligram per ml of iron. And the half-life of transfused blood is about 30 days. So that's studies from Jack Widnes. So if you give a baby a transfusion, you know that's approximately how much iron they're getting. And this is a study from our unit. Babies 24 to 26 weeks gestation. In the first 6 weeks of life, they had between 34 and 191 cc's of blood phlebotomized from them. So iron utilization primarily is for erythropoiesis in babies. And babies have to replace their senescent cells. They have to replace these tremendous phlebotomy losses. And sort of a hidden use is they need, just to keep a stable hematocrit, as they go from 1,000 to 2,000 to 3,000 grams, they triple their blood volume. So that's an important use of iron for these babies. And in order to do that, they need to absorb 0.4 to 0.6 milligrams of iron daily. So for preterm babies, the hematocrit is generally about 15 points lower than term babies at birth. So they have less iron that comes from the breakdown of red blood cells than do term babies. But this blood is, the iron from blood is recycled and used to make new blood cells. The estimated iron requirement for term babies is about 1 milligram per kilo per day. So these are some of the arguments that I faced in my unit when I started learning about iron and said, hey, we need to be giving these babies iron before 2 months of age. And they're like, oh, they're not born iron deficient. They don't need it because they're not making significant amounts of red blood cells. This was a big concern, and I think in the early days of neonatology, there were reports of red blood cell hemolysis in the presence of vitamin E deficiency. And many of the old codgers on our unit remembered this, and they're like, no, we give vitamin E for the first 2 months, and then we give iron after that. And then this was the other rationale. But it turns out that actually, if you look at blood in and blood out, the amount of blood that we transfuse is relatively equal to the amount of blood that we withdraw. So really, we're just replacing the blood that we phlebotomize. So what about side effects? People talk about fussiness, cramping, colic, reflux, flatulence. But actually, there's several papers that have looked at this. And in general, in babies, iron is pretty well tolerated. So here's the AAP recommendations. The bottom line is they say once you've doubled your birth weight, or by 2 months for term babies, you will have depleted your iron stores. So again, that's for term babies. And for some babies, this may occur sooner. For preemies, they recommend 2 to 4 milligrams per kilo per day, up to a maximum of 15 milligrams per kilo per day. Sorry, not per kilo, per day. So if you're on full enteral feeds at 150 cc's per kilo per day, you're getting 2 milligrams per kilo per day in exogenous iron. So many of our babies will require more iron than that. So our recommendations, this seems obvious now, but again, in our unit at the time that I started looking into this, our babies were not getting formula with iron. They were getting iron-free formula. And actually, the majority of our babies in our unit get breast milk, and they weren't getting supplemented. So those were big changes that we implemented. And then here's the other recommendation, is that iron-fortified formula should be or supplements should be continued for the first year of life. So how do we evaluate the iron status for babies? Turns out it's complicated for babies because many things are changing in the first 6 months of life. So they are transfused at odd intervals. They're phlebotomized regularly. Their red cell size changes over the first 6 months of life. So the hypochromic, small size, sorry, I'm jet lagged, of red blood cells doesn't really work for preemies or even term babies in the 6 months of life. Ferritin levels are changing. So everything is changing in these babies. Really, the gold standard is a bone marrow staining for iron, but nobody's going to do that. That's ridiculous. So what are we going to do? So I was doing a study looking at EPO, and as part of that study, I needed to look at iron status in these babies. And so I thought, well, I'll just get an iron panel, which is a ferritin, a TIBC, and transferrin level. And it took 4 mils of blood and cost $124. So there was no way that was going to happen in our preemies. And there's an elderly gentleman in the chemistry department who had actually worked on zinc protoporphyrin to heme ratios as an indicator of iron status in adults. And so, so I was very interested in that because it required 100 microliters of blood, and the test could be done in the same blood volume as a CBC with DIF, which we sent regularly on our babies, and it cost $24. So what this is basically the zinc protoporphyrin molecule is the heme molecule without an iron in the middle of it. So if it's got iron in the middle of it, it's called heme, and otherwise it's called protoporphyrin. And if it's got a zinc molecule in it, that means that you're iron deficient, and zinc is preferentially put into this molecule instead. So if you look at this ratio, if the ratio is high, that means you're functionally iron deficient. So we started looking at this in our babies to see if we could use it as an indicator of iron status in our preemies. And it turns out that similar to the ferritin levels, consistent with that, we saw that as you went from 24 weeks gestation to term, zinc protoporphyrin to heme ratios fell, indicating increased iron uptake over time on the third trimester. So these were levels that were drawn either from cord blood or from babies in the first week of life. So we looked at babies who got EPO supplementation. So these are babies who at time 0 had zinc protoporphyrin levels as shown here. These babies got EPO and iron, and actually because of the increase in erythropoiesis and iron utilization, the levels went up, whereas babies who just got iron showed a decrease in their zinc protoporphyrin to heme ratios. And this is the reticulocyte counts in the babies who got the EPO treatment compared to zinc protoporphyrin to heme ratios. So clearly there's a pretty linear relationship there. And then the other thing we said was if you give iron, you would expect the ratio to go down if it's a real reflection of iron status. And so we looked at babies who were supplemented with iron for 3 weeks, and the babies who were not given additional iron stayed the same, and the babies who received iron supplementation showed a fall in their ratio. So I guess my question is, can iron make a difference? And you know, we've heard about the dismal outcomes for our preemies, and this is one thing that we can actually make a difference in. This is something that's under our control, and so I don't know if it will make a difference, but it seems like from animal evidence, we know that being iron deficient is bad and contributes to poor memory and poor executive function. We also know that one of the problems for our preemies is poor memory and poor executive function. So it seems like optimizing iron status would be a good thing. Again, it needs to be tested because there's always downsides to things. No free lunch. So the practical points for this talk are to avoid both iron deficiency and iron excess in the perinatal period, to be aware that there's certain conditions that make you more prone to iron deficiency, and that there are potential neurodevelopmental consequences of perinatal iron deficiency. So in our unit, we follow zinc protoporphyrin to heme ratios regularly. So we do it every 2 weeks in our babies and then adjust their iron supplements accordingly. Sometimes the zinc protoporphyrin levels don't make sense, and so in those babies we get ferritins just to see if they match. We don't use ferritins all the time because you can have false positives with ferritins if the babies are, or false negatives, I guess. So high ferritins if the babies have a state of inflammation. But if you use them both together, you can get a pretty reliable sense of where the baby is. And then limiting phlebotomy losses and early iron supplementation would be recommended. So, just to share a little more, this is my puppy and my other puppy and my little girl and boy. Thank you very much. And my nasty pony, actually. Yeah.
Do you use early iron supplementation in babies with maternal fetal infections?
Yes. So early being, we start iron supplementation at 2 weeks. So we don't use it in the first 2 weeks of life because of the concern of the lack of antioxidants. But we do. Yeah.
How do you get the iron supplementation? Is it within the fortifier? Or is
So
it
we use Tribisol with iron routinely on our preemies. And we use supplemented formula. So if you are on full feeds, you get 2 milligrams per kilo, and many of our babies require 4 milligrams per kilo pretty routinely. So we'll add Tribisol with iron. So that's 4 milligrams per kilo, and then if they need extra, we use Ferrensol.
ferrosulfate?
Yes.
And with the milk or without the milk, or doesn't it matter?
So we usually, if they're on 6 milligrams per kilo per day, we divide it twice a day. And a lot of our babies are in continuous drip feeds, so we just put it in the feeds. So with milk.
Does it matter for the uptake?
Well, we don't really know. We're not measuring uptake, so it's hard to know. I mean, we follow the zinc protoporphyrin to heme ratios, and we keep giving more if their ratios are high. So.
Concerning the baby of diabetic mother and the IUGR, at what age you start and for how long?
So again, we measure ferritins or zinc protoporphyrin to heme ratios just to double check that they're iron deficient. But we start at 2 weeks and we treat for a year. Yeah.
What's the right way to consider babies after exchange transfusions, especially because of hemolytic disease? Because
Yeah.
they are destroying erythrocytes, so the iron is actually not lost.
Right, right. So we do one exchange transfusion every other year in our unit. So I don't actually know the answer to that. It's not a big problem in the States anymore. I think I was saying earlier at dinner, so when it's an event when we have an exchange transfusion, and we call our fellows from home so that they can cross off that.
They call me because I'm the only person who's old enough to have enough experience.
Oh, well, right. So the attendings have to come in because we're the only ones who know, and then we call the fellows in so they can cross that off their procedure log. So it's just rare in the United States. But I would guess that for the reasons that you said, I mean, you're getting presumably iron-sufficient blood. 75% of your iron is in red blood cells. So if you're getting adult red blood cells to replace the cells, you should be iron sufficient. So, yeah. Okay, thank you.